that area, in particular, an interest and focus in youth mental health, substance use, and especially as it affects racialized communities. And I identify as a Black woman, and so that's a community that I think I have more experience working with in terms of mental health and substance use. But in general, I think it's something that's near and dear to my heart. So I had to make it a bit more general in this context so that it would apply to Canadian women. But I did review some of the basic Statistics Canada data and I think the biggest thing, the most helpful thing is perhaps the insights around what this looks like clinically and what programs exist to address these issues. So I'm not an epidemiologist, at least not yet, so that's not my expertise, but I'll present that data and then provide a bit of context based on my experience. So yeah, as mentioned, I'll identify some of the key patterns, but really the hope is that we can go through some frameworks of that work with some of these programs and the specific programs that I found to be helpful, both in referring patients to, but even being a part of them and learning about the work that they do myself. So starting with substance use, when we look at some of those patterns, cannabis is the one that I'd start with because it's the most commonly used substance by women in Canada. And that has increased quite significantly post-legalization, which was in 2018. And when you compare the rates prior to legalization, it was about 11% compared to 19%. So that's quite a significant increase, but it has leveled out, and it's curious to see what that data looks like when we have more available in the coming years. But we do see that it's uptrending. And when you look at the graph that's on the right side, we do see the specific population that is most likely to use, and that use is increasing in 20 to 24-year-olds, which makes sense. Those tend to be college age, university age working youth that are transitioning to being legal age to consume, but also have access to it, have access to funds. So all those are factors that increase their use and the likelihood of use. The other thing is, when you think about some of the harms, unfortunately, those are most magnified in youth that are 15 to 19, considering that the prefrontal cortex of the brain, which is responsible for helping us problem solve and make good decisions, that isn't developed fully until between 21 and 25. So the fact that there is an increase in the number of youth in that age group of 15 and 19 using to about 22%, that's quite high. I do recognize that when they ask the questions in the survey, they ask if you've used within the past year. So with something like cannabis, it's within the past year. And so there are youth that may not actually be using frequently or have cannabis use disorder, which means have a dependence on cannabis, have symptoms of withdrawal when they stop trying to take cannabis, and have a functional impairment to their lives. So there's a lot of you who don't have an actual cannabis use disorder, but they do use, and the frequency of that use has the ability to impact their development. Some other factors to consider in terms of patterns of use amongst women include youth, as mentioned, lower income, concurrent anxiety or mood disorders. And I've seen this in clinic that people who have anxiety, they actually try to calm that anxiety with cannabis. And so they'll try and smoke cannabis to relieve those symptoms, or they'll drink alcohol as a depressant to try and treat their symptoms. And it's interesting and challenging because part of it has to do with access to care and lack of access to care. And so people try to self-medicate or self-soothe with cannabis. And I see this very frequently. And the last risk factor is first trying cannabis at or younger than 15 years old. And so when people start consuming in what would be a middle school or early high school, one, not only is their development, also when you think about the adolescent brain, their brain is different than the adult brain. The way they make decisions and how they spontaneously make those decisions looks a lot different from adults. So if you're accessing a substance that makes you feel good, and there is a less of an ability to delay gratification and look at long-term consequences, it makes sense that potentially perpetuates a disorder. And there's also other correlating factors. For example, if a youth who is in middle school has access to cannabis, then you think about some of the other factors like socioeconomic status, which is listed there, and other factors that could make it more likely for you to have access to cannabis at a younger age. Next is alcohol. This is the second most reported used substance by women in Canada. And the data here, it actually starts at 12 years old as opposed to 15 years old. And when you look at the data, they've been particularly interested not just in generic use, but or sporadic use, I should say, but in heavy drinking. And that's defined as having greater than 4 or more drinks on one occasion once a month in the past year. And I think clinically we tend to refer to this more as binge drinking. And when we speak to patients or clients, we tend to ask about binging or binge drinking because that's a bit more well known in the literature, and people tend to understand what we mean when we refer to that, but tends to be referred to by StatsCan as heavy drinking. And this is different because instead of it being associated with more lower income Canadian women, it's more higher income, and it's those aged 18 to 34. So it's a bit of a broader range of use. And those are some factors that are more associated with, unfortunately, heavy drinking. And even though men tend to report higher alcohol use, the same proportion of women as men report harms of alcohol. So lower rates of use, but similar rates of harm. And when we define harm, we think about factors such as there's something called the CAGE questionnaire, where you ask someone, as soon as you open your eyes in the morning and you're waking up, do you need to drink? Is your alcohol use or drinking, is that getting in the way of relationships? Is that making it hard to do your job? Have you lost your job? So you look at a lot of functional things, functional impairment, to get a sense of harms. And when people report those harms, both men and women who are using alcohol report similar rates of those unfortunate consequences or outcomes, I should say. And then the last group to think about in this context as well are mothers, and how the risk of drinking when a woman is pregnant poses risk more than just to one person, but to potentially multiple. And that in this case, when you think about use, that about 18% of mothers between the ages of 25 to 44 reported drinking during their last pregnancy. However, big caveat is that that's at an unknown frequency. It's unclear how much they were drinking. Did they drink a glass of wine before they realized that they were pregnant? Or did they drink a glass of wine here and there because of, the old wives' tale that's okay? It's very unclear. But I compared this to some of the fetal alcohol spectrum disorder rates of prevalence, because when you look at how many children are born with because of with the consequences of their mothers having consumed significant amounts of alcohol during pregnancy, that's between 0.1 and 3%, which I know is a huge range, but at most 3%. So we see that there is a pretty big gap between those two things. And so it does seem like there isn't really some clarity on the spectrum of use as it pertains to alcohol, but there are a large number of women who do use alcohol during pregnancy, which is why it's such an important component of prenatal screening when we do our assessments in clinic with patients in family medicine before they get transferred to obstetrics care or midwifery care. And as mentioned in the graph on the side, you kind of see these shifts, these changes. It's interesting that 15 to 19-year-olds used to use much more alcohol when you compare to 2008, and some of those rates have decreased. And some may say that there's more competition and use. And so when you think about something like cannabis, which is a bit easier to hide, you can hide an ounce, you can hide a gram even in your backpack, in your pocket. It's much harder to hide a bottle of whiskey or vodka. So when you think about the ease of use of other substances compared to alcohol, it does make sense why that use in teenagers is decreasing. And the other thing being that it's expensive. You need to have access to it from an adult, an older sibling. So those are also some factors that may be making it more challenging to access alcohol in order to drink amongst teenagers. Otherwise, the rates are pretty steady in other age groups. And in terms of opioids, so I wanted to make sure to include this, not because the rates of use are high necessarily, but because of the impact of that use, especially when it's very hard to manage the dependence that is highly associated with opioid use. So about 1% of girls and women, so 15 years old or greater, report problematic use of opioid painkillers. I'm going to emphasize that this doesn't include a very clear picture of what IV drug use looks like. It's specifically, a lot of it has to do with like oral consumption and medication. And so it's just not a full picture of what the opioid crisis looks like, because when you think of what happens in the context of overdose, which is the worst outcome, overdose leading to mortality or death, that it's hard to assess exactly how much this data captures that. in part because when you think about people who fill out surveys, if someone is using IV drugs and unfortunately doesn't have access to housing and to supports, the last thing they want to do is fill out a survey. I don't want to fill out a survey at times. So I can imagine someone who is precariously housed and navigating a number of other stressors in their life. So this data doesn't fully capture the picture here, and that's my huge caveat, but that it's still important to emphasize because even in people who otherwise can fill out surveys and are filling out surveys, that a lot of factors can lead to problematic use of opioids in women. The first one that I'll emphasize, and because it applies to my field, is chronic untreated pain. That chronic pain is much more likely to be present in women than in men, and often that the undertreatment of pain, which is worse in racialized communities, is often can lead to people self-medicating or taking a pill from their grandfather or from their uncle, and then realizing that this is they notice a stark difference between always being in pain and finally having a moment where you're not in pain and you can live your life. And that stark difference, unfortunately, can perpetuate that dependence. And it's not, I don't blame, and I think, well, I'm going to some of those frameworks, but it's really important to not blame people or penalize them for this use, because people are often suffering in this context, and that's what results in some of these challenges. And another study that I saw that was actually done compared rates between 2010 and 2021 of substance use in women pre-incarceration. So these are women who across Canada, prior to them being, they were already charged, they're about to be imprisoned, unfortunately, but just prior to that, what was their use? And they were asked about their use of substances. And in that population, they divided it based on province, and then they had Canada-wide. And alcohol was the most commonly reported substance, just like the rest of, or sorry, different from the rest of Canada, less cannabis use, surprisingly, than alcohol. And then opioids, so 12% compared to 1% of women otherwise in the country, are the most commonly used substances. And when they asked about severe substance use challenges, so once again, that connects back to dependence, withdrawal, functional impairment, that 40.8% of women in that study, and there are about 3,400, had severe substance use challenges. And a substantial portion, 23.7%, had a prior history of injection drug use. So you see that like a large proportion of women who are using IV drugs, that are in these precarious and very, I think, disenfranchised or marginalized situations that can lead to making it hard to fully understand what the rates are of use, but also make it hard to intervene, because being in prison is not the place that where full rehabilitation and supports are best administered, unfortunately, because of lack of funding, but also because we often don't look at people who are in prison as having as requiring dignity, but they do, like they're human beings. So unfortunately, when you look at the population that ends up imprisoned, that they often have like these substance use challenges and mental health challenges that are not being appropriately cared for in prison. And when they are released into the community, it becomes much harder to access those supports or care because of being further down that trajectory of impairment. And when you look at access to services, so in 2019, about 5% of Canadians reported harm because of substance use, but only about 1 to 2% of those reported receiving professional help. So it's much harder for them to reach out for help, to connect to a doctor. Part of it might be a lack of access to services, for sure, the cost associated with it, but also perhaps the stigma. And for some people, if they are struggling and they're noticing these changes in their life that are causing significant harm, there's also the need to desire to receive help, and that can also be very challenging for people. And mental health, I don't cover as much ground, but I do want to emphasize more from the mood and anxiety disorder perspective, in part because as a family doctor, that's what I diagnose the most frequently, that I don't have as much experience diagnosing psychosis and personality disorders, but that on a very regular basis, I am assessing and managing people who have are struggling with mood disorders and anxiety disorders. And we know that women have higher rates of those disorders, and this is based on Green Shield Cares and Mental Health Research Canada's paper that came out not too long ago, but it was last year. And we note that when you look at some of the factors that impact the symptoms of severe symptoms of anxiety and depression, that is much more likely to happen in women who are racialized and from 2S LGBTQIA plus communities, and that can affect people's access to resources. And when you look at that, racialized women are more likely than non-racialized women to report needing care. And so they recognize that they need support or they need help, but they don't access it. And that's by about almost like about 1.8 fold. So 5.62% of women versus 3.48%. And this is due to barriers, often barriers of lack of trust because of colonialism, because of anti-Black racism and other forms of racism, of not knowing what supports exist. So you know you need help, but you don't know what to turn to and who to turn to. There's also wait time. So if you connect with your family doctor, you connect with a nurse practitioner, then and you're being referred to a program, you may be waiting a year and a half just to access supports. And a huge factor is also cost, that a lot of these services are private and they require some type of insurance coverage, which often even then the insurance is not fulsome. Or they require out-of-pocket supports, which is very challenging to provide, and knowing that people are spending hundreds of dollars per hour to access these supports, and that's not sufficient for people who are from lower or even middle income backgrounds. And this was a study done called Mental Disorders and Access to Mental Health Care, and that was also posted on Stats Canada last year. And this is directly quoted from that page or from that study. The largest 10-year increases were seen among young people, particularly young women ages 15 to 24 years old, for whom the prevalence of generalized anxiety disorder tripled and that of major depressive episodes doubled. The largest 10-year increases were seen, as mentioned, among young people. So I think the challenge of that, sorry, that's duplicated, but the challenge there we know is that over 10 years, so from 2012 to 2022, that the rates of these diagnosed disorders are significantly increasing. And there are a number of hypotheses about why that's the case. People talk about isolation, we talk about the pandemic, which worsens isolation, we talk about inflation and economic disparity that can worsen these symptoms. There's so many factors that can contribute to this being the case, in addition to genetic components. And so as more people in our population have mental health disorders or diagnoses, and they reproduce, that increases the genetic predisposition for these conditions, which is also something to think about. But really, when we think about a lot of these conditions, it's not just genes, it's not just nature, but it's also nurture and the environment that people are in, the stressors that they're enduring, and the way our society doesn't actually help people to be well. That it's very focused on survival and trying to just push through and climb the ladder and survive. And people, unfortunately, women in Canada are experiencing the burden of this, and it's costing lives. And when you look at the proportion of Canadians that, when you look at how many had a diagnosis and you look at how many people accessed help, we also noticed, similar to substance use, that unfortunately a lot of people don't have access or don't access help. So about half of the 18.3% of Canadians greater than 15 years old who had a diagnosis of a mood or anxiety disorder talked to a mental health professional in the past year. So that's about half of people, I think it was 46%. And while that's much more than those who got help for substance use challenges, that is still a large number of people who are suffering without access to supports. And there are similarly a number of reasons why this may be the case. And it's important to investigate those challenges, investigate those barriers so that they can be addressed, because we know that the very real repercussion of not addressing mental health is that it affects our physical health. It affects, yes, the productivity of our society, but most importantly, it can literally cost people's lives and quality of life. And that's something that should matter to all of us. So what are some frameworks that are being used to treat substance use and to treat mental health conditions and concerns? And the three that I wanted to bring up and elaborate on are one, harm reduction, two, culturally responsive care, and three, concurrent disorder management. So starting with harm reduction, something that I'm sure that we're all familiar with, or have at least heard of, is a framework that I think is revolutionary in a lot of ways. Because when we think about how substance use especially substance use disorders were previously treated, they were treated with a lot of stigmatization and trying to bully people into stopping their use, assuming that that would be enough, that is what would allow for people to resist the urge. And unfortunately, when you think about withdrawal, when you think about what it means for someone to have been a dependent on a substance and then to try to stop it, it is a very physical reaction, lethal in the context of alcohol, or benzodiazepines. And unfortunately, people are like they suffering a physical condition, and that's something that requires empathy. So harm reduction focuses on trying to meet people where they are at and reduce the negative consequences that are associated with that substance use, realizing that there's going to be a number of people who don't actually want to be fully abstinent from these substances. There's some people who want to be able to live in proximity to those things, but decrease their use so that it's more functional and it's not as impairing to their life. And that is okay. So we kind of need a non-judgmental, non-coercive approach and services that support people, and also people who have lived experience providing that care where possible, because that also is going to sustain and support empathy when people have had that experience and they know the care they would have wanted or the care that they received that helped them, and it can then extend and provide that care. Next is culturally responsive, and there's a lot of different synonyms for this. There's cultural competence, there's critical consciousness, there's a lot of synonyms, I'll say. And I do want to emphasize that especially as it pertains to some of the like cultural safety language that originated in Indigenous culture, Indigenous practice, especially the Maori people in New Zealand. So I think it's important to realize how other communities, people have helped to create a foundation for even Black communities and other racialized communities to be able to develop frameworks like this to advocate for better care. So I'm grateful for that. I wanted to acknowledge that. And when we think about what it means to have culturally responsive care, to be honest, we use this framework or language, and I use it often, but there isn't really necessarily a set definition or a paper that I found on it. But the way that I see culturally responsive care looking is it acknowledges how cultural impacts health and adapts the needs of diverse patients. So there's an awareness and acknowledgement that culture is important. It doesn't try to put on the culture. It doesn't try and like reenact the culture necessarily. That's not going to be something that makes patients feel more comfortable. Especially if as a provider, you don't identify with that culture. But if you, what you can do, regardless of your background, is look at how healthcare providers like can make those adjustments and the power that they have in order to transform the lives of their patients. And it recognizes that there's a lot of systemic barriers that are related to racism that perpetuate and cause racism. And those systemic barriers are not the hospital, the clinic, your community health center, or your organization is not immune to these systemic challenges and because it's systemic. So it acknowledges that exists, and then it makes amends for that. It asks the person about ways that they can be supported, not just a part of themselves, but their full selves, which includes their racial and cultural identity. So it doesn't assume that every person from a particular community needs the same thing. It's just an awareness of how communities have historically and perpetually been affected. And when you keep that in mind, it makes you a bit more conscious of changes that you can make to your practice to support people. But if someone says, oh, I don't actually need that, then that's okay. And then there's concurrent disorder management. So this acknowledges that I'll spend very brief moment on this, but it's important that often mental health conditions and substance use are highly linked, and they're not always linked, but they're very significantly linked. And people tend to be or can be more open about one than the other. So someone might come forward and talk about their alcohol use, but then not talk about their anxiety and depression, especially if that's stigmatized. It depends on what's being stigmatized in their cultural context, but it's always important to think about when someone's presenting to you, and if even yourself, you're experiencing particular symptoms, or you're having challenges with substances, that you ask, is one affecting the other, and is the cause of one because of the other? And that's when you identify the root, you're able to better treat those conditions. And so that's, I think, really important to acknowledge, and that the use of certain substances and withdrawal from those substances can mimic certain mood and anxiety disorders. So if someone is in withdrawal, from alcohol, for example, then they can actually, it can cause anxiety or worsen pre-existing anxiety. So that's something to think about. And lastly, I wanted to emphasize some of the interventions that I've been adjacent to, that I've seen work really well, that I've shadowed. One of them being the substance abuse program for African, Canadian, and Caribbean youth. And they are changing the name at some point soon to remove abuse and to change it to use, to destigmatize that. But it's a program that was created for Black youth and for their families to focus on substance use and mental health concerns. And what I really appreciate about this is, other than it being having 8 locations across Ontario, and it's expanded and been funded to expand, that it's very culturally responsive, that they have Black healthcare practitioners in leadership and providing care, and as well as allies that are in position to be aware of what it means to provide culturally responsive care and to work alongside community to do so. And they have wraparound services. What that means is, when you think of someone who needs mental health or substance use support, often, and unfortunately in our system, you connect them to like a once per week counseling program, which, that's not to say that that's not helpful for some people, especially if they have more mild to moderate symptom burden, then that's helpful. That makes sense. That can continue with their work and with their life, and then they can go to that program. But for people who are experiencing moderate to severe symptoms of either substance use or mental health condition, having them pop in once a week when they already are struggling with stability is not going to cut it. So when you have these types of like wraparound services, especially at SAPC, it looks like case management, and that includes people who are aware of what it means to navigate the incarceration system and to be able to work with youth who have been incarcerated and to connect them with justice services as are needed, and to make sure that the staff there know how to work with youth who've had that experience. They have a psychiatrist, and so they're able to prescribe medication if needed for management. They also have personal and family counseling available to clients and their families. So to me, this is an example of like a community and outpatient program, but that really fosters wraparound services, holistic services for folks in a way that's a lot more effective. But I will recognize that it means that per client or per patient, there's much more responsibility and work required from the staff that are involved. And so the volume of patients that can be seen is much lower because of how much you're investing per patient. And then the second thing I want to emphasize as I wrap up is that the second intervention that stood out to me, because I was a learner, a medical student who I did an elective at Parkdale Queen West, and I was there when under the family medicine side of things. But one of the family doctors I was with for several weeks, we ended up going to like their supervised consumption services, or their site. And what's I think really powerful about this is that it wasn't as much as it was a supervised consumption service where people were allowed to use in with protection because they are in shelter and they're warm or cool if it's too hot outside. They have access to education and they're using clean, sterile needles. And these are all things that are extremely important, because they focus on the fact that yes, people are using, but just because someone is using substances doesn't mean that they are asking for HIV or hepatitis or they want to die. These are not things that we and people deserve dignity. So these types of services provide that to them. And they also have case management and advocacy and other treatments, and they provide shelter and housing as needed. To me, this is another example of wraparound services for people who are really struggling with moderate to severe substance use and are also struggling to access external supports, in part because often these are conditions that affect your function. And as a result, people lose their jobs and their homes, and they lose connection to family and to friends. And this can perpetuate use and also symptomatology from mental health conditions. So these types of wraparound services are so critical to the care and the recovery, even for people who are experiencing mental health and substance use. And recent announcements from the government to shut down, I think 10 of the 17 safe conception sites that are approved in the province is, I think, ridiculous and needs to be addressed from an advocacy perspective, because these are sites that are literally saving people's lives. So key takeaways are the rates of mood and anxiety disorders are increasing in Canadian women, and access to care is limited and inequitable. And I should mention that the supports that do exist that are available to people, the burden and the need is so high that they can only stretch so far. So even these amazing services I've just talked about, they have wait lists in some cases because there are just so many people who have need and not enough people to provide that. And so some of the things we can do is upscale some of these interventions, but that has to come through funding, that comes through staff, that comes through political leverage and advocacy so that we are reducing budget cuts and we're encouraging there to be coverage for some of these services. And I think also for anyone who is here who like works with patients or with clients, that thinking about how you can alter your own practice, that it's never too late to change, to adapt or adjust your practice, and to do so in a way that is going to, I think, transform patient care and transform even the way that you view the people, because it's not just about care, it's about how do you view people, how much empathy do we have for people, and that's something that unfortunately can dwindle over the course of our careers because of burnout, because of other factors. But when thinking about what it means to provide care to someone, these frameworks are not just words on a slide deck, they are concepts or pillars that I think are really important in order to be successful in supporting people and as mentioned, saving lives. So that is it. And it was, I think, helpful for myself even to put together this slide deck and to reflect on any of the new guidelines and even some of the factors that I think you see them in clinic and you see patients in clinic. And when you actually are like reviewing what that looks like on a population level, it confirms some of the things I've seen, and it also kind of adjusted some of the things that I've seen. So that was helpful. Yeah. I can't stay for much longer, unfortunately, only because I've been toying between clinic and working with my like the staff doctor. So I'm not sure if there are any questions, and then I